in the eyeball since 5 o'clock this morning. Yeah, that's what family members.
Yeah, family members. Um, there's um, some uh, some efforts to find a way to compensate people for that. But given the number of people that are doing it, which is a lot,
That's a lot.
that's going to be an interesting political thing to see happen.
They just need to turn this around.
Yeah.
And stop making it just, a money hungry,
Yeah.
industry. I mean, it's about saving people's lives. And maybe I'm an alien from outer space.
Well, the the issue for me is if we're going to be the kind of society that we claim to be, caring for people, all this other stuff, then we need to do that up and down the entire spectrum, from conception to planting them in the grave. And we need to be willing to pay for that. It's all well and good to say, okay, well, you can stay home with your family members and that's going to save society money. Well, it's not.
No.
Because then the family members are not doing anything else but,
and getting burned out, and then they get sick.
That's the biggest problem.
Yeah.
That stress is killing. Lots and lots of reforms have been tried. We'll see what happens in the future. I have little.
Something has to be done.
Yeah.
It's getting way out of hand.
Yeah. I have little faith in our government's willingness to do anything about it. Another form of long-term or actually terminal care is, of course, hospice care. There used to be places for the dying all through history. It used to be that, the dying stayed at home or wandered off into the hills and just died.
Are you serious?
Yeah, sure. Sometimes people, knowing that they were going, would simply leave. But people didn't have the same sort of, as far as I can tell, fear of that process. But now we have hospice, and hospice is, really didn't appear in this country until the 70s. And it has gone from there. The object is to just make people comfortable in their transition. So you keep them pain-free as much as you can. We mainly think of these as the only drugs they get are pain drugs, but really there's also anxiety agents and other things that can be used that they need. And then they help with planning for, they help with planning for like funeral and burial services and stuff. They provide some aid with that because most of us don't have plans in place.
None of them don't. But I know when my mom came in, Dad was in hospital. I was here. So he called that Monday. Dad was in hospital. I need to hurry up and come home. And I didn't get to leave. Trying to find where I stayed at work. My brother was in Colorado Springs at the time. So he needed to attend. He was trying to find where I stayed. So we didn't leave. We didn't leave Colorado until of course we passed away. But my mom was telling me about the nursing home. She said those people. It's like as soon as my dad got a certain level, I guess his breathing became whatever. She said those people Yeah, and they just grow everything. They grow food. They grow. I mean, it was just like, he was just, my mom said, I was just looking around. I was like, what is going on? They was just sitting for everything. I was just getting ready for the family. And everything. So I was just so impressed. And of course, I didn't get to see it because, by the time we get home here, it already had passed.
Yeah, well, that's nice.
Mm-hmm.
And now we get to the idea of respite care, which is temporary. It's temporary care in need. And it is also for, it is short term, but it gives the home caregivers a break. We have a number of people. That's basically what we have for my mother-in-law. Is we have people coming in to give us a break, specifically my wife, a break from having to be there all the time. The clearly this is something that we use. We pay for that out of pocket.
Really?
Yeah, there's no coverage for that. Could you get coverage? I don't know. I'd have to look. But we have. I'm not sure that it's not cheaper just to pay them by the hour. To tell you the truth. But it really is something that allows us to go off and, we've been able to go off and do things together, and know that we don't have to worry about my mother-in-law. We are fortunate we have a wonderful lady that is doing this. We were going to hire one, and then she had to go give care to her stepmother.
But these are respite are not for profit.
Pardon?
They're not for profit organizations.
A lot of them aren't. The organization we use is a not-for-profit organization, but you can get respite care through profit organizations. My father can't be alone. He has to have 24/7 care, and he's in his apartment, and it's he has somebody who stays with him all the time, and it's not cheap. But it's cheaper. If Medicare would pay for it, it would end up being cheaper than a nursing home.
Yeah,
and better.
The barriers is viewed as social, not medical.
Yeah. Yep. Yep. It's viewed as social, not medical, because we don't have medically trained people that come in. And it is to help with the issues of the stress of being responsible all the time for someone's safety. And my mother-in-law doesn't really understand that we can't leave her alone. I'll be fine. No, you won't. We can't trust that. Chances are, I'll say to myself, chances are that's correct.
Mm-hmm. As soon as you leave, you won't be able to enjoy whatever you're doing. You'll be worried.
Yeah. Just going for a walk around the block is enough to be actually concerned.
Mm-hmm.
But having someone else there, and we know that she's being watched. Right. The problem is if we go out of the house and she falls down the stairs, because one day we have a stair glide, one of the little chairs that ride up and down on the rails.
Yeah. We
have one for her to go down into our basement, which is where our laundry is. Mm-hmm. And she likes to do her own laundry, and great. Mm-hmm. She has her computer down there, so she goes down and about once a week gets on the computer and looks at her email. But one day she, for some reason, decided she couldn't figure out how to get her laundry down the stairs. Now, she had always come out. The laundry basket, she'd sort of nudge it along with her foot and put the basket right beside her chair, and then
Okay.
sit in the chair and lean over and pick up the basket.
Right.
Okay. Well, one day she couldn't figure out how to do that for some reason.
Huh.
So she put the laundry basket on the seat and sent the seat down, and then she walked down the stairs.
Huh.
Well, I was being careful. Yeah, right. And if you had fallen and social services got wind of it, we could be in trouble for elder abuse.
Right.
You know, and she doesn't understand that. So there's a real issue, and that's part of the other part of taking care of people in the home. You have to be careful how you do it, and you know, because any accident can be viewed by social services as neglect, and that can lead to criminal charges.
Wow.
Okay, so we also have adult daycare. There's various models for that. Yeah, you can. There are places that you can take your elderly people for the day, and it works.
Make get with other elderly people and
Yeah. Mm-hmm. We could take my mother-in-law over to the Chilson Center in Loveland, the senior center, and there are times when we will decide that we want to go to the gym, and we'll take her over there and just sit her down.
Mm-hmm.
And at least it's not specifically adult daycare, but it's an area where there are people that we can trust to sort of watch. And then we can go use the gym and pick her up. It's a pain in the neck, but we can do it.
Mm-hmm. So these are travel funds or private fees. That's how they are paid.
Yep. There are all sorts of things going on. Some of the new ideas are things like aging in place, which basically is a system of trying to keep the older and the frail and older people at home, and provide some support services of various, therapy and nursing help. But it hasn't taken over.
Yeah.
We haven't found it here.
Mm-mm.
The experiment so far has been successful in terms of, reducing hospitalization requirements, nursing home, and so forth. So the difficulty, of course, is that it's expensive. Somebody has to pay for it. So the idea of aging in place is a nice one. I mean, that's effectively what we're doing, helping her in place. But we have to take her out for her medical care.
Right.
When she came home from the rehab hospital after breaking her femur, we had PT and OT. OT came in and said, yeah, okay, you've got things set up, because we had grab bars and everything all over the place. But PT came in and worked with her, and an aide was supposed to come in and help her. She was not very gracious about that.
Really?
Mm-hmm.
The aide? She was not a gracious.
Mm-hmm. She did not like that.
Really?
She wasn't very nice about it. And this has made it difficult on us, especially on my wife.
Yeah.
So the other things, the sort of other sort of home-based, the continuing care retirement, the home, that's something that's still being developed. I don't know that we have anything about that, like that it's a formal program here. Haven't heard about it.
You haven't heard nothing like that?
And we've talked to the people at Larimer County about it a number of times.
Residents.
There's some campuses
Yeah.
for this, but those are going to be, continuing life communities. So depending on where you are, you have some alternatives.
Yes, these are the most expensive.
Yeah. And some of these things can be very expensive.
The continuum life.
Yeah.
The continuum life one is expensive.
Mm-hmm.
Not the CC. Is the CC also can be expensive too, right?
Well, I mean, it is. You have to pay. You pay the costs. If you're dealing with a not-for-profit organization, obviously, you're going to be paying certain costs. Yeah, and it's not staying in your home. Okay, it's an alternative to being in the home. And these would be for people that have no other choices, I would think.
Okay.
Part of the problem, as I see it, with these is that some of them, as I said, are definitely very expensive operations.
Fee-for-service contract.
Yeah, you got. Yeah, look at those fees.
Payment of
$100,000 to $1 million, and then monthly charges of $3,000 to $5,000.
Oh no! Oh no!
Yeah.
A trailer park. A trailer.
Yeah.
That is ridiculous.
Yeah. The
1%.
it's hard to justify, but it is a model. It is an idea, and it's what do we do? And we need to face this because we expect to have at least 75 million Americans above the age of 65 by 2030. Probably sooner than that. And we'll have several millions of people above 85. A couple of tens of millions of that. And people are living longer because medical technology has allowed it. So we've got lots of other ideas that are based on technology, but technology by its nature is expensive. If you can have a lot of these things at home, now they're even be able to do dialysis at home.
Oh, really?
Mm-hmm.
Not
Yeah, and
yeah,
dialysis is nasty.
Mm-hmm. He couldn't eat anything because come by. Come by. They lived in Tennessee, Memphis, and they come by the hospital because that's where he would get his dialysis. And I had an extra room. He was telling me that he couldn't eat. He had to eat like white bread. He couldn't eat like wheat bread. He had to eat the stuff that was unhealthy. I didn't understand.
Yeah.
Yeah. That was my mother.
Well, yeah. Dialysis is nasty. And of course, one of the latest innovations is long-term care insurance. And this is, again, the younger you are, the cheaper it is. But then you have to keep paying it, until you're done, until you use it. There are where they'll combine life insurance and long-term insurance. So one of the complaints originally was, okay, it's only for nursing care, and they scare you. They tell you that 77% of Americans will need nursing home stays sometime during their lifetime. Okay. I have continually, every time I've asked the question, I can't get the answer to this one. What's the average length of stay? If the average length of stay is less than Medicare's 21-day maximum that they'll pay for, then you have a much lower risk of needing to use long-term care insurance if you're over 65. The other question was, which you do get an answer to if you read the policies. But does that mean that they won't pay for the first 21 days? And the answer is, that's right. No. If you're over 65, they let Medicare do it. So I'm still bothered by the fact that I can't get an answer to the question of what's the average length of stay. Because I'm assuming from the fact that I can't get the answer that it's less than 21 days. And I know when my father goes in, he's got TRICARE, so they'll pay for up to 100 days. They generally have him out in less than 21 days.
Really?
Yeah. So what's, the insurance now is actually turned into a mix of life insurance and long-term care. So you buy a long-term care policy that will say that, let's just say that it's a $250,000 policy. If you need long-term care services, then you go in and they will start subtracting that out of your policy. So if you go in and you use, say, $50,000 worth of long-term care services, suddenly now your policy is $200,000, and that's also your life insurance policy. If you pass away before you need those long-term care services, then your heirs get the insurance amount of $250,000.
Wow.
Okay. And you can only, even though it's a $250,000 policy, apparently you can only use 90% of it. You have to have 10% of it that will go to insurance. So the question becomes, why have it? And why have it is, there's no reason to have it, to my mind, for just the long-term care. If you're also talking about it as a fairly substantial insurance policy, life insurance policy, then it makes a little more sense. So there's all sorts of, and the choices and the benefit structures are just all over the map. But this is something that's being really pushed right now, and the system itself will probably undergo some more changes. So what's going to happen? Well, we don't know. The problem is, I predict that we'll see some efforts to, as they say in one of these last slides, to your managed care provider networks will handle hospitalization and then longer term care at post hospitalization as an
Episode.
episode. And you can have various episodes, and we're
Okay.
already seeing that.
Okay.
And they have done this before, and the hospitals will be a little bit leery of it because they don't want to be accused of sending people out too soon just to have them bounce back and then start the cycle over again. Several hospitals have gotten some major fines and very heavy slaps on the wrist for that. Who knows what's going to happen? Our healthcare system is in such turmoil. We just don't know. Okay. So let's move on then to the mental health, because that's really one of the, let's see. Okay. Got that. So if we look at mental health services, we've had lots and lots of terms. I'm not going to go through the terminology changes here. That's easy to see. We are looking at a lot of different things. Instead of giving the old labels to what people have, we call it a mental health issue. We've been hearing that in the news lately a lot with what happened last week in Florida. They're now, trying to put mental health issues as part of it, but they've been cutting funds for mental health programs, and so they need to get serious if they believe that it's a mental health issue. We'll see what happens. I have little faith in this government. So the there's lots of history. We have a number of issues, what we used to call shell shock, we now recognize as PTSD. And it's being applied probably, I think with good justification, into a variety of different settings, battered housewives, that sort of thing.
Shell shock doesn't always mean you're shocked by a shell. I mean, anything, you can see something that really.
You watch your buddy blown up to bits. Yeah, that's tough. I bet you are.
They're getting ready to get deployed. Just in time.
Yeah, I bet you're happy. Yeah, but the lots and lots of experimentation has been done with mental health. I have my own views about using drugs to deal with mental health issues. Pardon?
You can get off of it.
No, you don't. That's part of the problem.
It's a life sentence.
Well, they don't tell you that.
They don't.
They don't tell you that. And many of them just don't work. So anyway, we have lots and lots of things that have been done. Drugs for various mental health issues have been tried. Some work, some don't. Psychiatric hospitals have a very poor reputation in the past about being awful places, places of abuse. And we also have a tendency to try to cover up such things. We don't want to acknowledge exactly the stigma. I've seen that in my family. So there's lots and lots of laws and lots of advances in various treatment modalities, drugs. We go back and forth on drugs and counseling and what's better and what's worse. We've tried various things like electroshock therapy. That's been pretty well debunked. Pretty well. It hasn't really done much. Lots of myths, lots of assumptions. There's a lot of old thinking that has been shown to be faulty, and we have been up and down on funding, especially federal level of funding for mental health services. The insurance people get involved in it and will only pay so much. If you look at a health insurance policy, they often put limits on the number of visits you can have to a mental health professional. And that's not, it has nothing to do with the quality of the therapy you're receiving. It's all about numbers. So we've had basically a lot of different choices. The moving people out of institutions into the community, closing psychiatric hospitals, closing down these programs has not done any good. Yeah, that's right. Many of them become homeless. Many of them end up being incarcerated. There's just really, we have a very poor record along that line. We have a number of different organizations at the government and local level where we have we've learned a lot. We're learning a lot about the chemical basis of and the genetic basis of mental illness. There is a genetic component. There is a lot. There is a lot. Oh, well. Don't talk to me about that one. I've had to deal with that a lot.
Yeah.
Yeah. It's no fun to find yourself there. So there's lots of, we have lots of drugs. Drugs have become a very big part of it. My feeling is that, first off, we need to define what we mean by mental health. And we need very broad health, or very broad term. And it can include things that range from seizure disorders to ADHD to, bipolar disease, which we used to call manic depressive disease, to schizophrenia, to clinical depression, to anxiety. There are many, many forms of disease. And the more we begin to understand the chemical basis, the more I believe that for many of these conditions, I mean, schizophrenia is a clinical disorder and it's a chemical imbalance disorder. The problem is the drugs turn you into zombie. Really, a lot of them. I know people. We know a man who's, I was going to call him a young man, but he's over 60, who is a schizophrenic, and he apparently is very intelligent, or was very intelligent, and that is one of the things. A lot of schizophrenics are highly intelligent, or were. He has a number of other issues that he deals with. He has he has a staggeringly good sense of humor.
Really?
He really does. I mean,
Wow.
he has a very good sense of humor. But the problem is he's drugged up, and
Oh.
you know. So, you know, we have. The more I hear about this, the more I think that there are mistakes. We can't just hand people drugs. We need to do other things. They need really good, focused counseling.
Mhm.
And we have a lot of people that get classed as having mental diseases, mental health disorders. And how much of that is the truth? To be honest, I have my doubts. I have severe doubts. That's my opinion. We tend to, you know, the statistics that are given here, 26.2% of Americans will have a mental disorder during any 1 year period. What do you mean by a mental disorder? You know? Yeah, I have no idea what that means. With 6% having a serious mental illness, with symptoms last with a duration of at least 12 months. Okay, 6% is still 18 million Americans. You know, so you know, I don't know what all that's supposed to mean. So there's all sorts of ways of looking at it. And this disability adjusted life years. I'm not sure. You know, I guess they're looking at total number of years lost to an illness or a disability or premature death. Okay. I'm not sure what that is, to tell you the truth. And it's figure 10.1. So let's go to the book and look at it.
10.1.
That's what they said. That's going to be on page 402. So we're looking at a set of 8 different disease groupings. Neuropsychiatric disease, cardiovascular, yeah, cancer, injuries, sensory organ disorders, respiratory disease, musculoskeletal disease, and digestive disease. Okay. So they're telling us that, what is this? This is a burden.
Burden of disease.
The burden of disease, leading contributing causes of categories to disability adjusted life years. So I don't know. I don't know quite what this is supposed to be telling us. It's not a great.
They embrace and grasp the concept that mind, body, say. I mean, you have to work. You have to treat. You just can't treat one and think the other one's okay.
Yeah.
So that's my philosophy. It's all interconnected.
Mm-hmm. Okay, so what they're looking at here is percent of total. Okay, so 28 point, almost 28.5% of the total disability adjusted life years in the United States and Canada are from neuropsychiatric disease. And we're told that at least $300 billion in costs are accrued each year, comprised of disability benefit payments from healthcare expenditures and lost earnings. Okay. So if we look at billions of dollars, and we look at the, let's see, serious mental illness, the total direct and indirect cost of serious mental illness. We've got disability benefits. Healthcare expenditures and earnings loss. Okay. Yeah. So a good portion of it, looks like 65 or so percent are from loss of earnings.
That's a lot.
That is, and it's tough on the people who don't have the earnings. But if we look at this, we look at these, we have a lot of so-called diseases. 17 categories and diagnostic criteria for 450 conditions. And there's usually at least a comorbidity of some sort. In other words, as you were pointing out, you can't just treat one. There's usually another. About half of the mentally ill have an additional disorder, like substance abuse. Okay, so over $300 billion. Who does and does not get treatment? Okay, look at that number. 45.6 million people over 18 years of age met criteria for one psychiatric disorder in the past 12 months. Only it's 19.6% of the adult population. Now, this next number is, I'd like to know, okay, does that mean that only 38.2% of these 45.6 million people have access to treatment?
If that's the case,
then yeah, right.
Yeah.
Right. Minorities, low income, uninsured, and rural populations are the worst served.
And they,
throughout the medical system.
Well, and talking about on the use of emergency room.
Yeah.
Something, I don't know if I mentioned this in the paper, but I meant to, is that in the urban and the poor areas, and people most of them are mental illness, ill person who are utilizing the emergency room just to get the free rewards or whatever they giving them
whatever they're after.
Right. And then they make it a habit.
Well, and that's a problem. I mean, this is one of the problems with the system. They have no other means of getting help. Substance abuse is really a problem. So let's look at barriers. Okay. We don't have enough people to treat the disease. Well, that's not a surprise. There's financial barriers. A lot of times people just cannot afford that. One of the biggest, I think, is the stigma about mental health issues. And then we have, what can be treated and what can't. Okay. And then attitudes, cultural issues, and our care system is broken. Okay. And really, one of the things, substance abuse and addictions, providers view as moral, not chronic diseases. I think that providers are wrong there. I think there is a real issue, but you don't treat it with drugs. You have to treat it other ways. How do people get out of alcoholism? Well, many of them join AA and they're successful because they have a support group. They have something that they don't get elsewhere. And they succeed because they are told from the beginning they can succeed. And they don't need to take other substances to help them. It's worse with children and adolescents, although we are so quick to diagnose our children with mental disorders in this society. You have a child who Goes into school, he's a little hyperactive. Somebody says, well, I think he has ADD. And who's saying this? A kindergarten teacher. I'm sorry, they're not trained.
It's just saying that. If the child on medication, child don't want to deal with it.
Well, and why do they do that? Because they've got 35 kids and one
Right.
teacher.
Exactly.
All you need is one disruptive kid, and
That's
it
it.
will destroy a
Yeah.
classroom. Unless you have somebody that can pay attention to them. And that we
Yeah.
used to have smaller classes, and it was easier to handle. Now, can't do it. Can't do it.
Mm.
There's a video from PBS from
Mhm.
Frontline called "The Medicated Child."
Mm.
That's about that.
Really?
Yeah, I get furious every time I show it in the classroom, all over again. I just can't stop myself from that reaction. That's my mental illness, maybe,
Mm.
but no, it's not. It's really, I can't stop myself from that action. It's just that angry,
Yeah. Yeah.
the way we treat our children. Um,
Mm.
there's all sorts of things. Psychiatric disorders, family members don't want to hear about it because of the stigma issue. People don't want to admit it. So they end up taking drugs. Drugs cause side effects. Side effects require more drugs. Pretty soon we have a drug addicted society. So we have, lots and lots of sectors to the to the treatment. We've got the psychiatric and behavioral health sector, which has a bunch of specialists, and they provide outpatient care for people. They focus on theoretically, they're going to focus on helping people manage their disease and do well. There's primary care, private practice, internal medicine. I firmly believe that no internal medicine specialist should be allowed to prescribe a psychiatric drug. It should always be after evaluation by someone who's trained in the mental illness sector and not just taken a couple of courses in med school. But our medical system has a hard time with that. Referring someone into mental health services is difficult. Human services, well, we have social services agencies, we have counseling services, we have all sorts of things, including religious and professional counselors who are functioning as religious leaders as well. Works and doesn't. Okay, so what's happened? Well, homelessness, under Reagan, we closed a lot of the facilities that took care of of people with mental disorders, threw them out on the street, and that's when we started having a homeless problem. We didn't have a homeless problem in this nation in 1980. So we, and this spurred petty crime and not so petty crime, and then incarcerations. And the growing of the prison system that has now become a private enterprise. And we have systems to where we try to keep our prisons full. So we pick on a lot of people to do that. There are a lot of volunteer and not-for-profit organizations that deal with these issues. My wife and I volunteered with an organization that dealt with counseling people who were abusing their children, physically abusing their children. They would be remanded into this program. We were volunteers, and we would go in there, and every time there was a session with the families, it was a counseling session, we'd go take care of the kids. And some of those kids were a mess. Yeah. It's really a shame to see children who are uniformly born brilliant and wonderful and happy descend into that sort of thing. It was heartbreaking.
A child is born with a heart of gold.
Got it.
The way of the world
Mm. Yeah, I don't quite put it that elegantly.
makes- It's a song by Elton.
Yeah, yeah. So, so there's a tug of war at our governmental level. Our federal Congress wants to cut budgets, and the states are the ones that have to deal with the results. And so there's a real back and forth push from the states to the Congress saying, "Don't do this. We will have to raise our taxes to make up for what you don't want to do." So we have lots of ideas for what we can do. There's all sorts of commissions that people put together for mental health systems. We're trying to make it more effective because we need to pull the stigma out. We need to put more effort on how to help people deal with these issues in a rational way. We cannot drug our society up. So we have to, more and more people are beginning to, again, in medicine, all through medicine, people are beginning to try and take a role in their own health. There's some parts of the Affordable Care Act that are trying to extend and rationalize and make more effective mental health care. It still costs money. And we really need to have our primary care people recognizing when they need to step out of the loop and turn it over to people who are much more specialized. I think we need to have the primary care people who already know they can't do heart surgery understand that they can't do psychiatric work either. Financing is very difficult. We have all sorts of approaches. People have private health insurance, which usually has some form of mental health built into it.
Very little.
Yeah, not much. We have Medicaid and Medicare. We have the states. There is no for ages that mental health was sort of shoved under the table. It was not considered part of what people needed to do. And what we're trying to do is make have that on a par with mental health as well as general medical care. We'll see how that works. There was a Mental Health Parity Act. It was a movement, but it actually had a lot of trouble. But we're trying to make sure that this mental health issues, which are a problem in society, are handled at a much better level. We're trying, we're finally beginning to recognize that mental health is an important topic. There's lots of issues. It's expensive because proper mental health care is practitioner intensive.
Mm-hmm.
You can't if you go in for your checkup and your doctor can give you 10 minutes, you can't do that with a psychiatric problem.
Like the medication. I don't really talk much to my mom. Just the couple of times because I've been on it since I was in the military. The few times that I said it, it's just her perception of, the myth and they don't want to talk about it. It's just like, oh, you need to stop taking those anyway. All you need is get on your knees and pray and ask, I said, okay, Mom, you do the same thing with your hypertension meds. Do that.
Yeah.
She didn't say nothing.
Yeah.
It's the same And it just you can't,
Right.
so
Yeah, I said this before, and I'm not a fan of any just willy-nilly any chronic drug.
right.
However, if the choice of that
Mm,
is a chronic drug or a major debilitating problem, then let's look for the right
Right.
chronic drug for you. Just like hypertension
Mhm.
medication, not
Yeah.
all of them work on
Right,
everybody.
right.
And when you start taking them, the cardiologist will put you on some, let's watch you, and then you'll see them change up,
Mhm.
change dose, change drug. He'll find a way to try and get the maximum benefit for
Mhm.
you.
And that's what happened. That's what they did for me.
Yeah.
But since I've been on the supervision, I have not been really. I have not. Just like
Here, have another prescription.
yeah, exactly.
No evaluation.
Well, the VA, the reason why I stopped going to the VA is they had me thinking that was done. Because yeah, I went there for a regular annual exam, and the lady took, came back with my blood results and said that your hemoglobin is really low. You can have anybody in your family got leukemia, you can have cancer, you can have a bleeding. I mean, she was telling me all this stuff. And no, I mean, none that I know of. And this went on for about 6 months. I was calling mom, anybody in our family had leukemia, blah blah blah. And this was along the same time when the VA was under a lot of scrutiny for
Mm-hmm.
falsifying people's records and stuff like that. It was around the same time frame. So something told me to get a second opinion. So I got my current family practice doctor. And I went and saw her and I told her the situation. I said, the VA's in, I got, thinking that I might have bleeding pollen, I might have cancer. And so she requested my records from me. And when she got them, she calls me and she's like, Maureen, your hemoglobin is fine. They got you in the system as a male. They're going by male ranges. For 6 months to a year, they had me thinking I was dying.
If I'm not laughing because it's funny, I'm laughing because it hurt.
Yeah, and I'm just like, my goodness.
Yeah.
So I had not been back to the VA since.
I can't blame you.
Yeah.
I mean, I guess theoretically I'm eligible for VA benefits.
Yeah, you are.
But I've never been.
Ever since that happened.
Yeah, I've never been to a VA facility.
Now my brother, who doesn't have insurance, has a post, PSTD, whatever. He needs it. He can use it.
Yeah.
But I don't understand why, he's has all those issues and he's in the drug rehab, and then they prescribe him 180 days worth of
hydrocodone.
Yeah.
Holy smoke.
Yeah.
Hmm.
Yeah. 180 days supply.
That's a lot of drug.
That is a lot.
At $30 a pill on the street, that's a lot of money.
That's a lot. I don't. Yeah, I keep my proper positions. Thank you.
Well, I don't blame you. I mean, first off, you have to trust your physician.
Yeah, and when that happened, I mean, it was good to sit in the living room, talk to the old war vets.
Yeah.
They always got their little hat on.
Yeah, they do, don't they? One of our neighbors is a widow,
Mm-hmm.
and she has a friend. He's a widower. They had been the two families had been very close, and so he lost his wife and she lost her husband. But he's 94 and a World War II vet, and we've talked to him a couple of times because both of our parents were World War II vets,
Mm-hmm.
so we have a little bit of a little bit of understanding of these folks, and it's really kind of interesting. But right now financing is very, very is very definitely undergoing some changes. ACA was supposed to help deal with that. We'll
Mhm.
see if the Congress actually allows it.
Mm.
And there's all sorts of efforts at cost containment. It's expensive to treat these diseases, but it's expensive to treat anything. Um, and we're trying to move mental health services into going away from a treatment model to how can we help people recover from whatever this is
Mhm.
and go on to become productive members of the
Mhm.
society.
Mhm.
And we want to integrate that with a full care issue. So
Okay.
it would be nice.
And
It would be
Utopia.
nice. Yeah, well, we'll see what happens. Okay, so that's the chapter on mental health.
What other chapter?
We have, let's take a look at, there's chapter 11, which is public health, which is
Right.
basically health problems that arise from people living in groups. So transmission of disease,
Oh my God.
sanitation, safe water and food, and looking to how we can help people with disabilities and serve low-income populations. Those are important considerations of of um, of of who we are. Okay, we have public health has gone up and down. It is a minute part of our expenditures on health.
Really?
It's a minute piece of that $3.2 trillion that we spend on health. And it probably, if done well, it can probably have a much greater effect than many of the other approaches we make by preventing the spread and dealing with strategies for combating disease. So public health is something probably to look at. There are lots of models. Public health has been with us for a long time. Public health as a part is responsible for cleaning up water supplies, for stopping the outbreak of disease. Public health efforts are what eliminated smallpox and have almost eliminated polio. But the we are seeing fewer and fewer. There's a lot of history about public health in the book, but we're seeing fewer and fewer efforts, and we're seeing cuts in public health services, including mental services. So we have a lot of things to learn about that. And I want to go to the chapter 12, which is about research and about the advance of healthcare. There's a lot of material in here on how we identify and find treatments and develop new technologies for health. And it really is an interesting topic. I know a lot about it because I was in the pharmaceutical industry for so long. Tremendous amount of money is spent on biomedical research in this country every year by the government and by the healthcare industry, meaning the pharmaceutical and device companies spend a lot of money on research. Obviously, their purpose in developing new drugs is to make money, but the ancillary side of that is that occasionally they have something that actually helps people. Well, it's a tough road. There's only, in a big year, we'll see 40 new drugs come out. In a slow year, we'll see 12. And it just depends. It's all based on data. And as we learn more about genetics and we learn more about biochemistry of the human body, then we see further treatments that will arise. Okay, so we have the whole section there on drug development. And another aspect of it is understanding epidemiology, understanding how diseases spread, what are the causes.
We have an epidemic person up in my division.
Yeah,
She work under the water.
yeah. Epidemiology really is a necessity. We need to understand how we use epidemiology to forecast needs, health needs. We also look at epidemiology as ways of predicting spread of disease, like the flu. And they don't get it right all the time because, of course, there's an old joke, if you want to hear God laugh, make plans. And that is joking on the square, because for sure we learn a lot that way. So there's a lot of different kinds of research, and so just looking at that and efforts to improve quality, and try to and understanding what the ethics of research. Taxpayers do support research on many things. Taxpayer money that's used to invent new treatments or new devices must be also used to patent these things and make sure that they're commercialized. They're brought into the commercial world. So there's a tremendous overlap between the healthcare industry and our public health. Okay, so it's now a little after 8:30, so it's time to quit. So we will quit here.
Okay.
Yep, we're quitting too. Yep, yeah, we moved back here.